Endocarditis. Endocarditis is an infection or inflammation of the endocardium, which is the most inner surface of the heart, also found covering the heart valves. It can affect all four heart valves as well as your chordae tendineae and interventricular septum. The infection is caused by bacteria, virus, or fungus that enters into the bloodstream from invasive procedures such as dental work, IV drug use, or implantable devices such as pacemakers. When a patient has a defective heart valve, platelets and fibrins stick to endothelial cells, which cause a thrombus. And when a patient has a pathogen in the blood, it can get caught in the thrombus and begin to grow. As the pathogen grows, it causes an inflammation response. However, the body cannot respond to the inflammation because the blood is unable to get to the affected area due to the thrombus. As it grows, it can break off and cause an embolism. It can also cause the heart valves to leak and send the person into heart failure. Risk factors include people with artificial heart valves or heart valves that are repaired with artificial material, a past medical history of endocarditis, certain types of congenital heart defects, abnormalities of heart valves resulting from having a heart transplant, and rheumatic disease, heart disease.
Endocarditis clinical manifestations. Subjective manifestations and objective manifestations. Subjective: malaise, fatigue, anorexia, back pain, abdominal discomfort, headache, chest pain, back pain, confusion, arthralgia, myalgia, weight loss. Objective manifestations: clubbing fingers, fever, murmur, dysrhythmia, tachycardia, splinter hemorrhages, petechia, ulcer nodes, Janeway's lesions, retinal lesions. Clinical manifestations secondary to embolization: splenomegaly, hematuria, renal failure, ischemia, gangrene, ataxia, aphasia, hemoptysis. Nursing assessment subjective data. The subjective data you should obtain from a patient with endocarditis is important health history such as any valve replacements, cardiac disease, infections, and births, past or recent surgical or invasive procedures and medications, patient health perception and health management, history of IV drug use or abuse, alcohol abuse. How has the patient been feeling? Any sense of malaise or other symptoms? Does the patient have any change in weight that they can't explain? Any chills or change in bowel or urination? How is their activity level? How have they been sleeping? Any change in sleep patterns? Any night sweats? Any pain? Has the patient had any headaches? Nursing assessment objective data. Objective data is you take the patient's vitals, note any signs of fever or irregularities. Examine the skin and body for any signs of ulcer nodes or on the extremities. Splinter hemorrhage under the nail beds. Janeway's lesions on palms and soles. Petechia, purpura, peripheral edema, finger clubbing. Listen to the lungs, note any signs of tachypnea, crackles, or any other irregularities. Listen to the heart, note signs of dysrhythmia, tachycardia, new murmurs, S3, S4, or retinal hemorrhages.
Some of the most important lab work to diagnose endocarditis is having two blood cultures drawn 30 minutes apart from two different sites. These labs will test positive for growth in 90% of patients with endocarditis. Electrocardiography. The infection will often cause changes in the conduction of electrical impulses that can be detected by an ECG or electrocardiography. Echocardiography uses sound waves to create a picture of the heart that can show a mass or vegetation that can indicate endocarditis. Diagnosis of endocarditis requires at least two of the following: positive blood cultures, new or changed heart murmur that can be detected by an ECG, or endocardiac mass or vegetation noted in echocardiography. No growth from a blood culture could be the result of antibiotic therapy within the last 2 weeks. Culture should be kept for 3 weeks to allow for slow-growing pathogens. No elevation in the erythrocyte sedimentation rate or C-reactive protein could be an indication that the patient does not have endocarditis. The cultures used.
Starting treatment for patients with infective endocarditis is important in controlling the infection. This can be done by gathering samples from the patient and sending it off to some type of lab source to have the culture evaluated and identify the present organism that is causing this infection. The outcome of this can result in long-term treatment, but it is necessary to kill the bacteria and help eliminate the vegetations that are growing on the heart. So complete elimination of the organism can generally take weeks, and treatment can be successful. And one thing to look out for is that relapses can occur in the future. Patients who are admitted with infective endocarditis are usually started with IV antibiotic therapy to help quickly eliminate bacteria. Fungal infective endocarditis and prosthetic valve endocarditis usually require early valve replacement and prolonged antibiotics. Valve replacement has shown to be helpful in managing infective endocarditis. And like any infection, an early sign can be a fever, which in this case is treated with aspirin, acetaminophen, ibuprofen, fluids, and rest. Generally not indicated, but patients who are experiencing elevated temperature and heart failure are usually put on bed rest. Heart failure and infective endocarditis can occur together, and the outcome of this situation is poor and can be life-threatening. So depending on the patient's condition, they may require more or less of treatment.
Nursing diagnosis. Decreased cardiac output related to alteration of the heart rate as evidenced by tachycardia. Activity intolerance related to decreased cardiac output as evidenced by dyspnea and exertion. Acute pain related to inflammation of the lining of the heart as evidenced by chest pain. Hyperthermia related to infection as evidenced by temperature elevation. Imbalanced nutrition, less than body requirements related to hypermetabolic state associated with fever as evidenced by weight loss. Ineffective breathing pattern related to pulmonary edema as evidenced by tachypnea.
Possible complications of endocarditis include stroke, infections in the other parts of the body, heart failure, myocardial infarction, and pericarditis. As for strokes, clumps of bacteria and cell fragments form in the heart at the site of infection. These clumps may break off and travel to the brain, lungs, abdominal organs, kidneys, and extremities. This can cause stroke and also damage to other organs and tissues. Signs and symptoms of organ damage are variable depending on which organ is affected. For stroke, the easy way to recognize signs of stroke is fast, face drooping, arm weakness, speech difficulty, time to call 911. Infections in the other parts of the body. Endocarditis can cause the development of abscesses or pockets of pus in other parts of the body, including brain, kidney, spleen, and liver. Abscesses may even develop in heart muscle, causing dysrhythmia. Signs and symptoms would include chills, fever, pain and tenderness in the affected area, swelling, and if lab work is done, a higher than normal white blood cell count. Heart failure, myocardial infarction, and pericarditis can be caused if the endocarditis is left untreated. Damage is caused to the heart's valves, damaging the pericardium. This in turn forces the heart to work harder to pump, causing heart failure eventually. If the infection progresses untreated, it is usually fatal. Signs and symptoms of a myocardial infarction include pain and pressure in the arm, jaw, chest, abdomen, shoulder blades, nausea and indigestion, shortness of breath, and fatigue. For heart failure, symptoms would include shortness of breath, fatigue, edema in the legs, ankles, or feet, rapid or irregular heartbeat, sudden weight gain or fluid retention, coughing, wheezing with white or pink blood-tinged phlegm. To reduce the chances of any of these complications occurring, the patient should be seen promptly to resolve the endocarditis and follow all orders to ensure resolution of the disease.